Welcome, everyone. I am Isabel, Renegade CEO, and I have had a ME for 43 years. I have dreamed of bringing clinicians together for a long time. This is the first step in a broader goal of networking clinicians globally in order to expand the pool of available clinicians treating infection-associated chronic illness. Long COVID has brought much needed attention to these conditions, and this is perfect for today's Long COVID Awareness Day. But where we are now is definitely very necessary, but not nearly sufficient. Our organization, as well as many talented researchers around the world, are looking for patterns, biomarkers, and mechanisms, but we need clinicians equipped to provide care and interventions that increase our function and thus our quality of life now. Most of the clinicians treating us have full panels, or the wait is months or years. So we urge you today to join us in this effort by sharing your expertise if you have been in the trenches with us, or learning from them if you are just getting started. Now I'll pass it on to our visionary extraordinaire and founder, Tess Falor.
Hi, everyone. I'm Tess, and like Isabel said, I'm founder of Renegade Research and Remission Biome, and I have had ME/CFS for 19 years now. Renegade Research is a community of patients, caregivers, clinicians, researchers, and other allies, all working together to conduct and push forward research and treatment of infection-associated chronic illness. And we're patient-led. We have a large team from all around the world. Some of them are here, but this is just a portion of our team. And we have bringing together patients of varying levels of severity and trying to create this diverse team and just push everything together forward that we can. I mentioned Remission Biome. It's our largest project, and we currently have 50 self-experimenters all working together as a community to try to understand remission events caused by antibiotics. You can learn more about Remission Biome at our new website, which I will show quickly here because it is beautiful. So this just went live today. So if you go to our website, remissionbiome.org, you can sign up for our newsletter. You can learn more about Remission Biome and our projects. So on the homepage, if you go to the bottom, click subscribe, and you will get on our newsletter where we'll announce other events. Like we have some other ones coming up. And yeah, join our newsletter. I'm gonna now have some of the team very quickly just introduce themselves and say how long they have been ill if they don't mind sharing. So I'll start off with Rochelle.
Hi, I'm Rochelle Sepulveda. I've been likely developing ME/CFS for the past 15 years, but was very mild until 4 years ago this month, and I got COVID, and that supercharged what I had to something that was a lot more obvious. So, and that really precipitated a significant decline. So, yeah, I suppose anything else that I need to mention?
We'll just keep it really short so we can just quickly go around and say names and how long. So I'll go to Shelley.
Hello, my name is Shelley Hayden. I'm so honored to have you guys join us today. I have had ME/CFS for 28 years, and I went 23 years without a diagnosis. And then 2020 hit, and I got long COVID on top. So I've been in the trenches with this for a long time. We're so happy to have you here. Thank you.
All right, I'll go to Nick.
Hi, everyone. I'm Nick Media. I'm a system scientist, and I work with the Remission Biome team. I got long COVID in March 2020.
All right, Ellie.
Hi, I'm Ellie Brocious. I was diagnosed with CFS 32 years ago, but I've had lots of infection problems before that. I was diagnosed with neurally mediated hypertension and POTS after that, and hypermobility. And then I joined the Long COVID Club in 2020. I'm in Northern Virginia, and I've had a support group here for 31 years.
Thank you. And then Michael.
I am Michael. I've had long COVID going on 2 years now.
All right, I will pass it back to Isabel.
Thank you, everyone. We are honored today to have Doctors Ilene Ruhoy and David Kaufman from the Center for Complex Diseases. They are working members of the U.S. Clinical ME/CFS Coalition and part of the Guideline Committee. Keep in mind, this is a brief summary of their bios as they are very experienced and accomplished clinicians. Dr. Ilene Ruhoy is a board-certified neurologist and environmental toxicologist who specializes in chronic and complex illnesses. She graduated from the University of Pittsburgh School of Medicine and completed her residency in neurology at the University of Washington, where she also did additional fellowship training in neuromuscular disorders. She earned a PhD in environmental toxicology at the University of Nevada, working directly with the EPA on her dissertation topic of pharmaceutical residues in the water. Dr. Ruhoy also completed a fellowship in integrative medicine with Dr. Andrew Whale at the University of Arizona. Dr. Ruhoy's interests include connective tissue disorders such as EDS, autoimmune neurological disorders, neuromuscular disorders, intracranial vascular and pressure disorders, infection-associated neurological conditions such as long COVID, ME/CFS, and PANS and PANDAS, traumatic and inflammatory brain injury, mitochondrial disease, neurodegeneration, and exposure illness. Dr. David Kaufman earned a BFA from New York University School of the Arts in Filmmaking, an MA from Teachers College, Columbia University in Education, and his MD from New York Medical College. Dr. Kaufman completed his internal medicine residency training in St. Vincent's Hospital and Medical Center in New York City. He began his internal medicine practice in Greenwich Village in New York City, just as the epidemic that came to be known as HIV/AIDS exploded. With St. Vincent's at the epicenter of this outbreak, he became deeply involved in the care of HIV-positive patients and in the research aimed at discovering ways to treat both the opportunistic infections they were dying from and the virus that was causing the destruction of their immune systems. As HIV and AIDS became a treatable infection, the practice expanded to include more primary care and general internal medicine patients ranging from 18 to 105 years old. He also became involved in the diagnosis and treatment of a variety of chronic, often difficult to diagnose and manage conditions, such as Lyme disease, fibromyalgia, chronic viral diseases, vitamin and nutrient deficiency. Dr. Ruhoy and Kaufman also are hosting the Unravel podcast on Patreon, which I encourage all of you to go and listen. And without further ado, please welcome Dr. Kaufman and Dr. Ruhoy.
Thank you, Isabel. That was some introduction.
Really?
I always get emotional, David, every time I hear about your history starting out in the AIDS epidemic and when we didn't know anything. So,
Yeah, I still do as well.
yeah, a lot of good work. So we're very happy to be here. And I guess, Isabel, you can let us know how we can best get started.
I'd like to say just two things before we hit the road here. First of all, thank you for doing this. I think it's incredible that you're able to bring all these clinicians to see this. All right. I mean, that's been a goal for Dr. Ruhoy and myself for since we've known each other, basically. And for me, it's something I'm very passionate about because we just don't have enough physicians to take care of this population of patients, which, as you all know, is exploding. The second thing I wanted to say is it's really interesting, Isabel and Tess, as you were introducing everybody, in quotes, the role that COVID and long COVID has played here. And you know, if ever there was a silver lining in something, the silver lining in COVID is bringing attention finally to these chronic infection-mediated illnesses. So it's just great work you guys are doing. Thank you.
Thank you very much. And yes, if we can get started, just talk about what you do in your practice, how you approach patients, what tests you order, you know, what's your rationale for going one way or the other, and you know, how your patients are benefiting from this and what you've done along the years.
Ilene, you want me to start?
You can start. Yes.
I'll start. Okay. So I think the most fundamental thing in my approach and in Eileen's approach as well is taking a history. So that sounds pretty mundane. And for any physicians who are watching, that is drilled into us endlessly in medical school. We cite people like Dr. Osler, who talked about the history. It's so important. But sadly, it almost never really plays out in the real healthcare world for a variety of reasons, including lack of time, insurance systems, et cetera. What became clear to me is that taking a history really in detail is the critical step in figuring out what's going on with our patients. And when I say detailed, I start with the patient's mother's pregnancy and delivery, and I go literally through the history from 0 to 2, 2 to 5, 5 to 12, 12 to 18, and in sections like that, because I found it very revealing in terms of informing me or helping to suggest to me underlying conditions that might predispose to illness. And a classic thing, for example, a patient comes to me and says, I got COVID in 2020 and I've never been the same since, quote, therefore I have long COVID, but I was totally healthy before that. And then when you take that history that I just described, they have a history of chronic ear infections and chronic sinus infections, and then they had exercise-induced asthma, and they had rashes from certain foods, and then they developed some medication allergies. They have a couple of episodes of dizziness in college, and they played sports, and they kept twisting their ankle and spraining things. And all of those pieces of history are profoundly relevant to putting the long COVID in quotes, putting it into context and understanding it. So for me, that's the most critical piece. And I will spend the initial patient visit is scheduled for at least 90 minutes. And I would say that 60 plus of those minutes are simply taking the history, back and forth talking. So to me, that's the ball game right there. If we as physicians spend the time to take that history, everything else kind of starts to make sense. Rather than say, oh, you have long COVID or you have ME/CFS, which really tells me nothing. Those are just two labels. They're devastating labels, perhaps, but they're labels. They don't explain the underlying pathology. I'll stop there, and you can, Eileen, if you
Well,
want to
I
add
couldn't
anything.
agree more. And I've often thought about this, and I realized that when I trained in neurology, I trained in both pediatric and adult neurology. So I have always sort of had this approach where I would ask about, for an adult patient, where I would ask about the childhood. And I would often find that there was evidence of what I would see when I worked at the Children's Hospital in the neurology department. And so I started to put together how this had been somewhat of a lifelong struggle, or at least that it had its beginnings earlier in life than the age at which they're sitting in front of me, or at least in their story, they might say, 2-3 years ago was sort of when it all really seemed to get worse. But actually, as you say, there's evidence that there was something brewing, something simmering earlier in life. And so I think that's a real important part of the history, because it does lend itself to this idea that this is a progressive disorder. And we know that, not everything is in a acutely post-infectious. Some of these things sort of take a little bit of time to show itself, at least clinically. We know that physiologically things are happening, but at least clinically, it's not apparent to patients or doctors even earlier on, until you sort of take that history and collect the pieces of the puzzle. And so I completely agree with you, David, that I think it's an important part of the history taking that, unfortunately, medicine has changed to such an extent where we're not given a lot of time with patients, at least in the insurance model way. So a lot of doctors just don't have that luxury of being able to take this very long, extensive, comprehensive history, which is one of the reasons why David and I both went into private practice. I mean, separately, we didn't go into it together in the beginning, but we both had those reasons for wanting to do this in a private practice environment, because we would be able to give the patients at least a little bit more time to really ask those kinds of questions, because it is very time consuming. So I agree that the history is a very critical component to understanding the patients. And the reason why it's important, in addition to all that we've already said, is that I think the approach which I know everyone likes to ask, like, what do I do for patients? What's my approach? It really, I mean, there's a lot of obviously general approaches and a lot of same things that I do for each patient, but a lot of it is tailored to the patient itself. And that's where the history plays such an important role.
Right.
And the symptoms that they've been struggling with, and and importantly, what symptoms have gotten worse, what symptoms are impacting the quality of their life. It really does give a flavor to that patient that can really tailor and help me sort of tweak an approach differently for that patient versus the patient before them or the patient after them. So I always like to sort of start by saying that there really is no blueprint. There really is no template. Again, there's a lot of generalizations that can work and cannot work. But it really is very tailored, at least at this point in the game, because we're still learning. We're still, I mean, long COVID, as David said, the silver lining is that we're learning a lot more about what happens to the body in these kinds of post-infectious states and post-exposure states, I should say, because it's not only infection, it's most commonly infection, of course, but there are other exposures. So anyway, I think I'm rambling now.
So let me
Back to the floor.
let me add a few specific thoughts on the history taking. And again, this is especially directed at the clinicians that are listening. So we all know how to take a history, we're all taught, but one of the things that's become incredibly important and clear to me over these last 10 or 11 years is things that honestly before I wasn't necessarily as focused on. So part of the history for me is, where has the person lived throughout their life? What countries, what states, what parts of the US? Because that alone begins to tell me something, or at least suggest things that I need to look for. Did they live in an area with endemic tick-borne infections? Did they live in an area where they might have had a Zika infection or whatever? So that's number one. Number two, occupation. All right. I have met so many patients where it turns out nobody asked the patient's occupation, and the patient is a veterinarian with an amazing exposure risk for infections, or they're a field biologist, and that changes, not changes, but it adds such a layer of important information. Another thing that I find useful is if a patient says, you know, I was given antibiotics, I will often say, well, when you took the antibiotic for your sore throat, did anything else get better? And I can't tell you how often a patient will say, well, now that you ask, everything got better. I completely felt better. All my symptoms disappeared during that short course of antibiotics. And again, that's a tip-off. It's a flag to tell me I better go down that road as well as all the other roads that are coming up. I mean, I could go on. There's lots of other examples, but I just want to emphasize again the critical nature of that history taking. So for me, after I've done this history, which is never really done, but it's the first leap at it, I'll do an exam, physical exam. For me, the exam is not nearly as detailed, I think, as Ilene's exam. I do sort of the usual stuff, looking for orthostatic changes in blood pressure, signs of connective tissue disorder, looking at the skin for markers that might be relevant to mast cell activation syndrome, and then the usual chest, heart, lungs, etc. Listening for vascular abnormalities and what are called bruits, and you know, can I palpate things that I shouldn't be palpating, stuff like that. And then come back and sit down, and the next half hour or so is spent with pretty much me talking, trying to put in context what I think is going on. Again, with the thinking that the ME/CFS is a label, it just means that check boxes from the IOM criteria, consensus criteria, have been checked. Doesn't tell me anything. It tells me the person's fatigued, they have PEM, they have orthostatic, brain fog, and they have aches and pains. But if I stop there, we both leave the room knowing nothing other than now I have a label, which most of the world doesn't recognize anyhow. So to me, the goal is to dive under that label, both for ME/CFS and long COVID, which to me are very similar, like overlapping, and look for the key things that I think are drivers of the illness. And usually, you know, I don't want to sound arrogant, but usually by that point, I have a pretty good idea of the various different pathologies that are occurring that has make this person so ill. And we can go into that, but I'll let you talk now.
Well, I don't really have much to add to that part of, I mean, I do the same. Yes, I do a more thorough, I don't want to say thorough is the wrong word. Your exam is thorough enough. But I do a neurological examination, which has a lot of pieces to it. So I do that full exam because I want to be sure that I comprehensively examine them neurologically and make sure that I'm not missing anything. And there, I often will find something on exam, something focal on exam. And I think that's always an important piece of the puzzle. Although I don't always find something, sometimes it's a completely normal neurological examination, so it doesn't necessarily contribute. But then I sit down and I talk more with them, and I've already, usually have reviewed a lot of the records that they send with regards to previous labs and previous other workups and other testing that they've had. And I just put together a story about what I think is going on and what we could potentially do about it. But it usually requires sort of a next tier of diagnostic workup. So it depends sort of where the patient is in their journey. Oftentimes, I'm not seeing them until they've seen many different doctors already. So lots of workup has been done. Sometimes I even ask, why was this checked? Why was this panel looked at? Like, to see if they have any insight for me, because sometimes I don't know what that particular doctor was looking for. And so then I'll add my own diagnostic recommendations. And sometimes I can easily get it done. Sometimes I can't, because insurance can get in the way often. But I will recommend a second tier of diagnostic workup, and then have more discussion with them about what I'm looking for and why I'm looking for it. And then I often, like to hold off on making any particular medication recommendations until I have my workup back, which is usually labs and some imaging and some other panels that come in kits. I do a lot of genetics to sort of see what variants hold, because I often wonder, like, well, why does one person get sick and the other person doesn't, yet they've had the same exposures? And that's, something from my environmental toxicology training that we often think about we did at the EPA. So I do that workup, and I often will say, I want to sort of understand more of your physiology before I make specific medication or treatment recommendations. But I also feel very strongly that they've been suffering for many, many years. So we'll recommend, sort of the low-hanging fruit of things that we all regularly use because they regularly have benefit for patients. And I don't hold back on recommending things like mast cell stabilizers or antihistamines, or some other, like low-dose naltrexone, some things that can sort of take the edge off of the pain and the fatigue that many will experience. And so I'll give those more generalized recommendations, and we'll get them started in the hopes that they can have some clinical benefit while I'm doing my diagnostic workup. I will say many times the patients have already tried a lot of those low-hanging fruit medications, and they'll tell me that they either didn't tolerate it, or it didn't work, or they had an adverse effect. And so I note all that down so that I don't continuously recommend it, which can happen if I don't remind myself that they did not tolerate a particular medication. But so there's a lot of, so that whole first visit, there's a lot of sort of interaction that goes on with me and the patient to sort of decide how we're going to proceed and what we're going to do next and how we're going to do it.
So let me try to go to some details, okay? During this conversation after the exam and the history, I usually will try to break it down into what's some of you may have heard us now call a Septad, which I've discovered is not actually the right word. I thought that meant 7, but I'm totally wrong. So now I don't know what to do, because we've used that term for years now. So the Septad is referring to this kind of eureka moment and recognition that most of the patients we see who come in with either an ME/CFS, long COVID, mast cell diagnosis, whatever, they actually have in common 5 to 7 different pathologies. And it's astonishing how often that's correct. I mean, it's very rare for me not to find that to occur. So I'll walk through this with patients. So the first is an autonomic nervous system dysfunction, which really takes up 2 spaces in the septet in my mind anyhow, which is POTS, which I use very loosely as a term. Probably safer to call it orthostatic intolerance, which I think is an enormous driver of illness in all of our patients, regardless of whether the patient says, well, I stand up and I don't get dizzy. That's not the only criteria. So POTS, and then the other aspect for autonomic is gut motility disorder, GI motility, which inevitably, almost inevitably, is associated with small intestine bacterial overgrowth, which is another completely treatable major driver of illness in our patients. So we're already talking about two big drivers, which are diagnosable and treatable. If on exam or by history or both, it sounds like connective tissue disorder, hypermobility, I'll discuss that. It is truly amazing to me how often our patients have a connective tissue disorder. And I'll say, before I started doing this work, the first 35 years of my career, I probably never thought about it. I mean, it never occurred to me to look for EDS in a patient. So it's there. And then mast cell activation syndrome, which sometimes it's obvious. Patient says, I can't eat. I have a very restricted diet because anything I eat makes me sick. It causes a rash. It makes my heart beat fast, causes brain fog, causes fatigue. But often it's much more subtle than that, or it's suspicion based on history. The example of the patients I said who had frequent infections and sinus stuff and exercise-induced asthma, et cetera. And then for me, a very big one is looking for infection. Does the patient have a risk for reactivation infection of vector-borne illnesses, Borrelia, Babesia, Bartonella? We all have EBV, as we all get infected with EBV, CMV, HHV6. We all can have reactivation of those diseases. Many ME/CFS patients have a history of mono. Could they be having ongoing reactivation, especially of EBV? So that becomes part of the discussion. And then as this discussion is laid out, it becomes obvious to a certain degree what the workup should be. So then we move on to testing related to these 6 or 7 different pathologies that I'm describing. And the testing is arduous for the patient and can be expensive. I've learned that I'm relatively infamous in the LabCorp and Quest draw stations because my patients have 35 to 40 tubes of blood based on the orders I write. I will readily admit I don't follow the teaching that physicians had, which is you order a little bit and then based on that you order more. Basically, my attitude is the patient's been sick for so long and not had a diagnosis, I'm not going to waste more time. I order a lot of tests. Interestingly, although patients come in routinely saying, I've been to doctors and doctors and doctors, and they say, oh, my tests are normal. In fact, I always get abnormals back because I'm doing much more detailed testing on immunology, immunocompetence, infection, hormonal stuff and nutrients, et cetera, mast cell, of course. And then, as Ilene said, I do these kits. I always look for small intestine bacterial overgrowth, positive in over 80% of patients, even if they don't complain about GI symptoms like bloating and gas. I almost always do saliva cortisol testing because most, if not every patient has HPA axis dysfunction. And I may do tick-borne disease testing, although I usually wait until I see the other stuff unless the history is just glaring. I think those are the basic tests, right? I don't necessarily do imaging in the first visit, although I may be suspicious of connective tissue disorder causing cranial cervical instability or similar type problems. And then, as Ilene said, I will usually consider some initial medications, but very limited. So I often will, if I'm suspicious enough, excuse me, I will start histamine 1 receptor blockers, antihistamines, and histamine 2 receptor blocker, which is famotidine or Pepcid. And I always discuss low-dose naltrexone. It is a game-changing, remarkable drug, which just can be so effective. But I rarely will go beyond that, even if I'm sure about POTS, because I want to get better testing first. And I should have said, and another test I always do is the NASA lean test, the 10-minute leaning test, which I find remarkably informative. And I use that all the time then to titrate and adjust medications. Your turn.
Well, I agree with everything you said, of course. And obviously, at some point, I think the panel can interrupt us if there are questions that, that I think this was meant for us to help answer questions to those who have registered. So I don't want to take up all the time and us just sort of talking about what we do, but I do want to add that I do exactly the same. And with regards to the POTS diagnosis, I mean, as you know, I feel like it's sort of the tip of the iceberg. There's a lot of dysautonomia, autonomic dysfunction that sort of underlies the POTS presentation. And I do like the tilt table testing. I like the Nasoline test because obviously patients can do it at home and it's easy and it's free. The tilt table testing takes away the component of the skeletal muscle activation. So it's a little bit more reliable. And in fact, sometimes patients like will barely meet the criteria on the Nasoline test, but when you put them on the tilt table, they meet the criteria easily. So but yes, it's much easier for them to do the Nasoline test at home. And it's hard to find a tilt table test, as I've learned throughout the country, because I have patients, through everywhere, and it's hard for me to find where I can get them an autonomic. I actually prefer the entire autonomic testing, as you know, that just not the tilt table. I mean, there's also heart rate deep breathing, there's the Valsalva, the QSART, and so on, but it's hard to find that. So, we do the Nasoline test. But yeah, you're right. Unless the heart rate is in front of me is sitting at 120, I will perhaps start a low dose beta blocker just because they're uncomfortable at that heart rate. They feel they feel exercise intolerance. They feel short of breath. They feel like they're not getting enough blood supply to their brain. So I will try to lower the heart rate a little bit to just sort of minimize those kinds of symptoms. But you're right. Until I get more objective data with regard to their autonomic nervous system, I don't go forward with any kind of real more aggressive treatment plan than that.
So I want to jump in and say something about the Nasoline and the autonomic testing. This is a conversation Ilene and I have often. Okay, I find the Nasoline just incredibly informative and revealing, and so often I have patients come to me with their tilt table test and they were told it was completely normal. And then they do their Nasoline and it is not normal. And part of the issue is perhaps what we call normal and not normal. Okay. So there are very strict criteria for POTS. It has to be greater than 30 beats and you can't drop your blood pressure and all that. And I think, as often happens in medicine, we therefore miss a lot of diagnoses. It's like saying there's a normal range from 0 to 10 in a lab test, and if you're 1, that's still normal. Well, 1 might not be normal. It may be abnormal, especially in the right setting and context. So for me, I want to emphasize, at least in my opinion, when I have a patient do a Nasoline test and they're lying down and their blood pressure is 120/80 and the heart rate is 66 or 68, they stand up for 10 minutes and their blood pressure, let's say it just doesn't change, so I can get rid of that variable in this conversation, doesn't change, and their heart rate goes from that 68 up to 90, or no, it goes to 68, goes to 78 to 80 and stays there for 10 minutes. That's not normal in my mind. If any of the people listening who don't have an illness stand up for 10 minutes, your heart rate does not stay 20 beats above normal. That's not normal, right? We have reflexes, thanks to a million years of evolution, to deal with that. And then you revert back to your baseline, give or take a few beats. But that patient would not qualify as POTS, and they would be told their tilt table was normal. So I just think we need a little bit more liberal definition here.
No, I agree. And I think the important point is about the symptoms, right? So if you are symptomatic from that sustained elevation of heart rate, that to me, that's a deal breaker, right?
Right.
That's an autonomic disorder.
And symptomatic doesn't mean just dizziness or lightheaded. It means brain fog. It means fatigue. It means blue feet, yellow hand, white hand, purple colored hands, speckles, lividio. It's very important to look at all the pieces together and see what is normal versus not normal.
Great. Do you want us to continue just talking about our approach?
Yes, you can do that. We have questions whenever you're ready. Some people have asked if you could share more detail about the most important tests that you do, and what that list is.
Sure. So for me, in terms of immunology, I'll do immunoglobulin IgG subsets, not just a total. most of the time patients come to me, they may have had an IgG total without subsets, and very often the total's normal and there'll be subset deficiencies, which may be very relevant and very important information. I look at the other immunoglobulins, you know, A and E and M, and I'll do lymphocyte subsets, which look at T cells and B cells. It is and continues to surprise me, excuse me, how often a patient who has ME/CFS or long COVID, especially if it's a long history, will have abnormally low B cells. B cells are the cells that make immunoglobulins, or will have abnormal T cells, or will have very high IgG subclass 4, which may suggest chronic infection. So it's very, useful information. I always do antibody testing for the herpes family of viruses, because yes, we've all been exposed, but I want to see what the levels of those antibodies are. That may be instructive. And I now routinely, on the initial visit, initial labs, will do EBV PCR testing, because I've learned that just because the serology for EBV looks okay, I often am getting EBV positivity on the PCR DNA test. So to me, that's a crucial test now. I'll do the mast cell testing, which initially for me is plasma histamine, chromogranin A, and prostaglandin D2. Those are very difficult tests to get done properly. In fairness to the lab, they need to know and be able to immediately draw the blood, immediately spin it, immediately aliquot it, immediately freeze it, and make sure it's frozen until it gets to the lab. That's daunting, and most of the time doesn't happen. So negative labs for mast cell don't rule it out in my mind. I don't begin with the urine testing for mast cell because it's even more difficult for the patient. If the initial labs are negative, I might then go to urine testing. If a patient has had endoscopy done in the past, within the, recent enough that the samples are still in the pathology department, which is like 5 to 7 years, I'll request some special staining called CD117 to look for and get a quantitative count of mast cells per high power field, which often gives, confirmatory histologic diagnosis for mast cell. I will do, some hormonal testing. As I mentioned, I do the 4-point saliva cortisol testing. I'll look at, a vitamin panel of all the usual vitamins. What am I forgetting? I do an antibody panel, autoantibody panel. Although I have to say that keeps changing. I can't decide what the best panel to do is. And sometimes I will order panels that are not available from LabCorp requests, particularly a lab in Germany called CellTrend, which has a panel now of 16, I think it's 16 antibodies, keeps growing, with autoantibodies that have been associated or can be associated with orthostatic intolerance and POTS, and now also with long COVID antibodies that we find in long COVID patients. I'm sure I'm missing some, but that's a big quick overview. Ilene, you do some neuro stuff too.
I do. Yes, I do. There are very few, unfortunately, there are very few biomarkers for neuroinflammation, but there are a couple, like neurofilament light chain. I'll do the neurofilament light, and then I'll also do the neuron-specific enolase, which is a marker of neuroinflammation, usually from hypoxia. And then I'll obviously do a lot of different autoantibodies with regards to certain immune-mediated neurological diseases, because it's a fatigability disease. And so I often will look for things like I'll do a myasthenia gravis panel just to make sure that there isn't a component of that. And sometimes I actually find it. I find one of the acetylcholine receptor antibodies on the panel is slightly positive, and I never really know what to make of it. I don't necessarily diagnose the myasthenia gravis, but I think that maybe this antibody is playing a role in at least their presentation of fatigability. I do a lot of the immune studies that David had mentioned. I have found real use in doing the subclasses. I mean, 1 and 3 have been known to be associated with autoimmune diseases, so I find that to be supportive evidence, and then 2 and 4 with infectious disease. So, what we try to do is we try to find labs that help to support and or explain the phenotype of the patient, the clinical presentation. And I do, I think a lot about the connective tissue, as I'm sure everyone on this call knows. It's all I feel like I ever talk about, or at least I'm never asked to talk about, but which is odd for a neurologist, right? Because connective tissue is not our jam. But I've really gotten into it because over the years, I have seen where connective tissue really plays a critical role in how our body responds to disease and exposure, and how our body can heal and how our body can recover. And the mast cells, we always talk about the histamine, but it's got almost 1,000 different mediators, if not 1,000 or more. But a lot of them, most of them are inflammatory. Some of them are proteases, and they actually degrade collagen. But the chronic and systemic inflammation that happens results in a degradation of connective tissue, really no matter what. And so, which is why oftentimes, years into an illness, patients will describe things like muscle pain and joint pain and just diffuse body pain. In fact, there's a lot of chronic pain syndromes in the fatigue and illness world, in my long COVID patients, in my ME/CFS patients. There's a lot of just sort of chronic pain. The meninges are connective tissue, and so a lot of my patients have changes of intracranial pressure, which contribute to their symptoms. And the vessels themselves have a layer of connective tissue, so they're very compressible. And I always say, with the slightest mechanical pressure, they can just compress, because the connective tissue is it's become a little bit friable and architecturally unsound. And that's just from the chronic inflammation. I think what happens in these diseases, and again, a lot of what I say are just sort of my thoughts and theories, and my goal is to prove it one day. And I think a lot of the research that's coming out of the long COVID world is starting to sort of show what we see. And so this idea that, this chronic inflammation, we all have endogenous stopgaps that we're born with, basically, that when there's an inflammatory response to an exposure, our body sort of, fights that exposure and then sort of knows when to back off. I think with these chronic illnesses, especially when there's reactivation of these viruses that we're all exposed to, I think we lose that endogenous stopgap. And so there's this perpetual inflammatory response. And so it just sort of, chips away at the connective tissue, frankly, which holds our entire bodies together. Our spine is just a series of joints, right? So I see a lot of spinal manifestations in patients that don't technically have a history of hypermobility, but we know that hypermobility is a risk factor for a lot of these diseases. So there's just a lot of uncertainty, but yet a lot of certainty, if that makes any sense, right? We don't have all the answers, but we're seeing patterns. And I think these patterns are really important, and we need to focus in on them. And that's obviously one of what Dave and I always talk about with regards to our goals for these patients, to understand them more. And I'm real excited about all the research that's going on. And, but I always feel like my role is like, I'm the clinician, just like on the ground, boots on the ground kind of thing, where I'm just trying to help people. And while I am involved in a lot of research projects, I really just sort of feel my primary role is just, again, trying to alleviate some of the suffering that's going on right now. So I don't know how I got off on that tangent, but it was just talking about, so I do, and then, there is like in the neurology world, when like for neuropathy, this is an example, like there's a neuropathy panel that we do that, I will always do, which includes things like looking for blood like dyscrasias, like multiple myeloma or amyloid, because those two, by the way, those diseases can have autonomic dysfunction as well. And we obviously check the thyroid. We look for certain vitamin deficiencies. We look at glucose metabolism, which we also know plays a role. I very commonly see hypoglycemia in these patients. I very commonly see cytopenia, so they have low white blood cell counts. And so I do that so I do a very like classic neuropathy panel, which while most of them have neuropathy, it's really because of the overall disease that I'm trying to find answers for. So yes, I do add a lot of neurological specific lab tests, but I do imaging. I'm 90% of the time I'm ordering imaging at the first visit. If they hadn't had recent imaging of their brain and cervical spine, I'm usually ordering it just because I do think about obviously the brain. And I also want to look at the cranial cervical junction. And then so I'll follow it up with even vessel imaging, frankly, because I'm always worried about compression, because we know a lot more about compression syndromes and the diseases of which they're associated with, specifically the symptoms that they're associated with. And most of the patients have these symptoms. So I would just like to rule all that up front, because I always say that, if there's an anatomical problem, like all of my medications aren't going to help. They're not going to fix it. They might, in some ways palliate the symptoms a little bit, but they're not going to fix the problem. And so if there's an anatomical component, I'd like to know it for the patient sooner rather than later. And so I'll just do the imaging usually at the first visit, if not the second.
So I just want to add something and emphasize something that Ilene said, which I think is crucial. So in terms of emphasis, in terms of connective tissue, it is not only about hypermobility EDS, and I can't say this strongly enough. It is chronic inflammation, excuse me, which is injuring connective tissue. And the difference between an EDS patient and a non-EDS patient, both of whom have ME/CFS, long COVID, et cetera, is that glass just overflows sooner for the EDS patient. Meaning that they start out half full, and then, or maybe I should say half empty, and then they have chronic inflammation, which just chews away, just nicks away, death by 1,000 cuts of that connective tissue, but they're already damaged, their tissue, and therefore they have a problem sooner. But you don't need EDS to end up with the same connective tissue disorders that we are seeing, such as CCI, craniocervical instability, and it's all about inflammation. That's the name of the game. It's chronic inflammation. And one of the areas or things I've been thinking about and talking about and waking up at night thinking about is, in fact, what I think is the similarity between the diseases of aging and the ME/CFS long COVID patients. So in the diseases of aging, it's got this fancy new name called inflammaging, which is a fancy way of saying chronic inflammation. That's what our patients have. And if you start looking at it through that perspective, or put it in that context, our patients have a kind of premature aging secondary to chronic inflammation, which means that we need to go after every possible source of inflammation in order to reverse that tide and make them get better. I want to add something on testing. As I'm sure Ilene will agree, I have an order set, like physicians with EMRs, we have order sets. You press a button and there's my 40 tests or 50 tests. But that is constantly a work in progress. I can't tell you how often that has changed over the years. As I learn more, I go to a meeting, I get onto my online 500 plus doctor group, and we discuss something, and I say, oh my God, I should be ordering that test. So as an example, a recent addition is this long test that I just name in my EMR as the clot test. Okay. These are tests to look at the patient's propensity or vulnerability or risk for clotting. And the reason I'm looking is all this data that many of you know about with the whole quote microclot issue in long COVID and ME/CFS. It's very real. And the more I look, the more I find that patients have, an undiagnosed factor V Leiden, which is a risk factor, or a PAI1 genotype that puts them at risk, or a constantly positive D dimer showing they have small clots. And it now opens up another road that we can go down and manage and treat. So I just want to emphasize that it's always changing.
That's an important point, actually. And I always say the long COVID research is showing us so much more about
exactly
CFS, and I definitely adopt what we're learning about long COVID and what I even learned in my long COVID patients, and I apply it to the ME/CFS patients that have been suffering for years. And the endothelial dysfunction and the hypercoagulable states seem to be a real key player. And it's just because of the means of how they just damage, not the vessels, obviously, which is where it starts, but then it stagnates blood flow. You easily develop clots of differing sizes. In fact, as we know, during the pandemic, we saw an increase in strokes and heart attacks. So it's not just necessarily microclots, though that seems to be behind the long COVID, the chronic fatigue, the chronic organ dysfunction, these endothelial dysfunction with these small clots that clog up those small vessels. And we just did a podcast about that, David, because it really does seem to be holding great concern for a lot of the long COVID clinicians out there about what role this is playing in organ dysfunction. And when I think about the brain and how it's fed, with regards to large vessels, medium vessels, small vessels, and then those tiny vessels, and I think about how those small vessels feed all those crevices. And I realize, and we've long known that there's small vessel disease in the brain, and it's what we refer to when we see those hyperintensities and those flare signals on a brain MRI. And so, when I get imaging on my ME/CFS and long COVID patients, I see diffuse white matter disease, as it's called, related to small vessel disease. And so then I start thinking about, well, how are we going to fix this? How are we going to reduce the risk of clot formation, to repair the lining of the vessels so that there isn't as much platelet activation and platelet aggregation and platelet stickiness. And so there's some ways that we do it, and that's part of the treatment, I guess, talk of this, but it really seems to be a very important component. And when there's constant reactivation of these viruses, hence constant chronic inflammation, all of that gets worse, right? So we have to get ahead of the game. We have to rein it in and then get in front of it, is how I see it. And that's what I've started to try to do. And, I worry, as you know, David, because I'm always telling you my worries and fears. Like, I worry about, this epidemic of basically cognitive impairment that's headed our way, if it's not already here. Because I know there's a lot of brain fog. When I do cognitive testing, thus far, knock on wood, it seems fairly stable and normal. But I hear what patients are saying. They are experiencing, I think, something that we don't label yet in neurology, because the standard cognitive testing always appears okay. But they are experiencing a slowing of their ability to process information, to react, to recall words, to remember what they were doing in the midst of a task, to keep up with conversations. And so that's very scary to them. And I get that, frankly, and so I worry about, now we have small vessel disease and chronic neuroinflammation and microglial activation and astrocytic dysregulation. And I really do worry about the brains of all of these people.
Yeah, we have a lot of questions.
Oh, okay.
This has been absolutely amazing. So are you guys ready to get started with some questions?
Yeah.
Yeah, I actually would like to say one last thing first. Okay?
Sure.
Always
Talk
got to get the
forever.
last word, huh?
What do we do,
So
the
I want to,
podcast?
right.
We had so much to say.
I think one of the really important takeaways for the clinicians listening is that we were taught, again, I keep going back to how we were taught and trained, right? Generally to think in single organ systems. In fact, the most medical school curriculums, at least when I was there, you have neurology and you have urology and you have GI, and you just go organ system by organ system. And the issue here is that these patients have multi-system, multi-organ, chronic inflammatory disease everywhere. And it almost requires a change in the brain. I think the reason, it's interesting to me that the largest groups of doctors who are seeing these patients tend to be internal medicine, family medicine, amazingly ER medicine, because those groups tend to have been trained or think in terms of total body illness, not just one organ at a time. And the second piece, particularly with this concept of the septad, is that each of these pathologies interacts with the other. So you have a mast cell degranulation moment, that's going to knock down your POTS. You're going to have trouble with your POTS. You have a leaky gut from small intestine bacterial overgrowth, that's going to cause a leaky blood-brain barrier, and you're going to have brain fog. It's all together, interacting. And again, we're sort of, most physicians are not trained to think that way, let alone, of course, don't have the time to dive into it. So it's the reason we spend so much time on the history, the explanation, and these huge, crazy workups, which we could be criticized for, but it's because of, yes, we are, but it's the nature of this illness. So I just wanted to close out this little part with that.
Absolutely. Thank you. Patrick?
Yes, thanks so much, you guys, for putting this on. I'm a tumor immunologist, a medical oncologist. I have a daughter, 23 years old, with long COVID POTS, very debilitated from this, a lot of post-exertional malaise. So I study the immune system, and I know there's some agents. I totally agree with you about chronic inflammation. The question is what to do with it. There's some really great papers by Akiko Iwasaki and others
Right.
looking at the immune response. Really, we know a lot, but the question is what to do about it. There's studies of efgartigimod to block the antibodies, which is really a great study. I'm glad we're getting some cutting edge agents, but there's many other cutting edge agents that are available in the rheumatologic community, and I don't see them being used for POTS or for long COVID that I think could be effective in cutting off inflammatory signals, T cell subsets, soluble CTLA-4. There's even an investigational agent of a PD-1 agonist I learned of. There's type 1 interferon receptor blockers by AstraZeneca. How can we get these really exciting agents into long COVID POTS? I think they may be effective. Patients with long COVID look like patients I gave interferon to.
Oh, yeah.
Right.
The doctor, and so I think if you block interferon, it really could be helpful. How do we get these agents to patients?
Well, I mean, I have been prescribing immunotherapies now for the past, I would say, 4 to 6 months. I really dived into that. I agree with everything that you just said. And I think a lot of the newer immunotherapies, specifically the ones that are more targeted, as some of them that you had mentioned, have been showing great promise. And I've been using, in fact, like things like Vygart and things like Kineret, Copaxone even, I've used in patients. I've used there's various kinds of I even went to the old guard sometimes, like the cyclosporins. Like I've used lots of immunotherapies, and to be honest, with great response to a lot of them, and not to all of them, and not with every patient, of course. And I'm trying to find that one that seems to be the answer, and I haven't arrived at one yet. But I agree with you. Right now, there's a rapamycin trial going on to sort of look at rapamycin and its role. And both David and I use rapamycin regularly, and we see patients respond to it. There's a particular immunotherapy called Ibudilast that is not available in this country, but a couple of my patients were able to access it from other countries and are really doing well on it. And I don't know why. It's a phosphodiesterase inhibitor, and I don't know why it's not available in this country, to be honest. I'm sure there's a reason, but it's not. But it seems to also show great efficacy for a lot of these patients, and their symptoms specifically, by the way, their autonomic symptoms. So I agree with everything you said, and I think we need more trials to really decide what it is we want to target in those immune pathways, and we need an immunologist on board, and we need a rheumatologist on board. So yeah, I completely agree with you. And I'm finding great success with an immune therapy approach. I mean, I've done a lot of IVIG and rituximab, and now even plasmapheresis over the years. And that's what led me into immunotherapies, right? Because they were effective, but they're expensive, usually a pain in the butt. I'm not going to curse on this program. But, if you want to hear me swear, you can see that's on Patreon. But so that's why I started to use some of the more oral immunotherapies that are still hard to get approved sometimes, though the old guards are easy to get approved. So yes, I agree. And I'm excited about that area. I really am. I'm excited about that treatment plan.
So I of course completely agree with you as well, Doctor. What I would say is it's impossible or nearly impossible to get those biologics, those agents approved for our patients. So it's bad enough how much money our patients spend to see us and on the testing, but I can't get approval for a $100,000 a year drug. And honestly, I don't want to get into politics too much here or at all, but I can't help it. It troubles me that the NIH and the sort of at the federal level, they're looking at studies for these biologics, the PD-1 inhibitors and all these other agents, which are really exciting, but virtually unattainable for our patients unless the FDA overnight makes an indication that you can give these drugs for long COVID. And I guarantee that's not going to happen for years. So what do we do for our patients? So I think you're right. Those drugs are great. If we can get them, that'd be wonderful. And they do carry more risk. But realistically, I have patients that I'm going to see on Monday who need treatment right away. So I look at immune modulation with more easily available things. So naltrexone modulates that immune system. Talk about a cheap drug with virtually no side effects that's there. It's just sitting there. I started using it back in HIV disease in the 80s. It's an amazing drug. Rapamycin, I am like That's one of my recent obsessions. It can reduce inflammation. It can alter the whole immune system, restore homeostasis, increase autophagy, and take care of potentially a lot of the underlying pathology system-wide. As Ilene mentioned, IVIG, immune modulator. Ilene and I have become very interested in plasmapheresis as another way. Unfortunately, very expensive, but not nearly as expensive as the biologics. Another, I don't know what to call it. I can't call it a drug. Another thing is exosomes. Unfortunately, not FDA approved, so we're extraordinarily limited in its use, but it is a remarkably effective molecule, or not molecule. What do I call it? It's not a drug, right? I don't know what to call it. So there's other stuff out there. Even some of the NSAIDs. I find Celebrex reduces inflammation more than, say, ibuprofen. Works in some different ways. You mentioned rapamycin, Keita, as you mentioned. I mean, there's a lot of stuff out there already on the shelf, not necessarily so expensive. So yes, those biologics and those agents look great, and we should learn about them. But I'd rather see the research dollars directed at more readily available stuff that doesn't cost so much money and has less side effects.
And we could also get the biotech companies to realize it's such a great big market that
Yes,
they
right.
should want to do
Yes.
research in this
Right.
area. And I don't think they realize that.
They
long
don't
COVID
realize
still a
it. I've
secret.
said that before. I'm
Yeah,
like, they could
exactly.
make a fortune if they let us study their drug in this patient population. I
And
have
I'll give you, I'm sorry to interrupt, Ilene. I'm going to give you a perfect example of that. Peptides. Okay, so something Ilene and I love. I've learned so much from Dr. Ruhoy about peptides. And then the FDA, in its infinite wisdom, banned peptides. They said no peptides. I mean, boy, I felt like I sounded like Trump just then. And that's really damaging, right? There's a peptide called thymosin alpha 1, which has profound immunologic benefits, increases NK cell function, natural killer cell function, is antiviral, and is approved as a drug by the FDA in this country, but it's not available. And I've met with the company that makes it and say, look, you got a drug that's approved, bring it back, let us test it in our ME/CFS patients. Before it was banned, I had great results, but it doesn't happen. It's a kind of bizarre.
It's very bizarre. I mean, GHA was another peptide that actually promotes the formation of collagen. And so for all of my connective tissue patients, they had such great response. I mean, I would say 80% of them reported improvement in decreased pain, in their mobility. They were able to do more with a lot less pain and discomfort and with a lot less fatigue. And it was banned. So I stopped. I couldn't get it for them any longer. So
And these things were banned not because something happened, just to be
Right.
clear. It's not like somebody
Oh,
had a dreadful infection from a peptide given sub-Q injection. So
no, not at all. In fact, it's actually still being used in burn centers because it is so great at promotion of healing. So it's still available, but only under very specific indications and in specific context. So yeah. So I mean, we can go on about this topic.
Yeah, a quick reminder, if you're a clinician, you can raise your hand and come on camera to ask your question. And next we'll have Maria Afsal.
Hello everyone. Can you hear me?
yeah.
I'm Dr. Maria Afsal from Pakistan, and I'm really glad to have found you people, the panel, and I was actually waiting for this kind of discussion because I'm interested in autonomic disorders. I aspire to be a neurophysician, and I also happen to be a dysautonomia patient. So I have a lot of questions and my own experience to share if you allow. So basically, I have dysautonomia for the past 9 years, and I also have syringomyelia at C6-7 level. So there's been a lot of controversy about it. Half of the neurophysicians and surgeons that I've seen believe that syringomyelia, it has nothing to do with autonomic dysfunction if it is in the cervical spine. But half of them believe that it can actually cause, and theoretically, when we look at the cross-section, it should be able to cause. Secondly, I do have symptoms that make me believe that I can also be having mast cell activation syndrome. So when we look at mast cell activation syndrome, syringomyelia doesn't fit in the picture. And when we look at syringomyelia, I feel that mast cell activation doesn't fit into the picture. So firstly, I had to ask about it. is there any connection between syringomyelia, especially in the cervical spine, and mast cell activation syndrome? Secondly, I had a question about the NASA lean test. I wanted to use it for research purpose, but the literature that I saw, it was hardly used anywhere. Although I know that clinicians use it regularly, even here in Pakistan. I have seen clinicians do that. And once during my house job, that's like the foundation year, I have myself diagnosed one patient who was being treated for dissociation in psychiatry. But I had this observation that her symptoms used to get relieved when she lied down, and they were always in the upright position. So what I did there was that I performed that test on her. And it turned out that her heart rate used to spike up to 150s without any decrease in blood pressure upon standing. And she was started on beta blockers, still table test was advised, but she unfortunately lost follow. So these were the few things that I wanted to ask. And in addition to that, I wanted to ask the cutoff for the ganglionic acetylcholine receptor autoantibodies for autoimmune autonomic gangliopathy.
Yeah, I mean, I regularly test for those antibodies, and it's on the cell trend panel that Dr.
Right.
Kaufman referred to. But you could just get that one, the alpha-3 one alone on like LabCorp or Quest. They do have that option, but the full panel of the different autoantibodies that are associated with dysautonomia goes on the cell trend panel, which right now is the only option to test for those antibodies. As far as I know, I don't think Mayo yet offers them, but and then with regards to, so your syringomyelia, so do you have a Chiari as well?
No, I don't have Chiari and I don't have EDS either. And I've got all the vascular imaging of the head and neck done, and there's no abnormality there.
And do you have any evidence of intracranial pressure abnormalities, high, low?
No evidence of that, but a few times I felt that I'm having throbbing headaches along with bradycardia and vomiting.
Okay.
A few episodes isolated.
Yeah, so I mean, it's hard to answer. Like, I'm trying obviously not to give medical advice, and we should have sort of made that point earlier on in this program. But just to answer your questions in a generalized format, so it's thought that syringomyelia is sort of due to elevated intracranial pressure, and so there's sort of this pressure transduction that's sort of where the fluid extravasates within to the cord and creates this cystic space basically, and then but it's often associated, and I'm sure that you know, with the Chiari, and that's thought to sort of what is impacting the lack of appropriate CSF flow and changes of pressure and volume, and which contributes to the syrinx. And then if you correct the Chiari, we actually see the syrinx reabsorb and sort of resolve on its own. So that's why I was asking that question. And so if there isn't Chiari, I'm sorry? That hurts. So if there isn't, so the question,
any other
okay. So the question is can it be related to autonomic disorders and or mast cell activation?
Yes.
I mean, I think, again, there's a lot of uncertainty, and what I say are just sort of my thoughts and opinions. And people can argue and disagree with me. That's fine. Many do. But, I think that there's a lot of mast cell component to this, because I think if you don't have evidence, although you did say you had some symptoms that could be related to intracranial pressure, specifically high pressure. And so mast cell activation, if it's chronic, it absolutely can increase the volume of fluid within the CSF spaces. It can also increase blood flow as well, as does autonomic disorders, right? It changes blood flow. So what happens in the brain is that there is exchange amongst the fluid compartments, so the arterial and the venous system along with the CSF compartments, and that's actually how the lymphatic system works on a very simplistic level. There's a lot more complexity to the lymphatic system, but it relies upon the exchange that goes on between these fluid spaces of the brain. And so anything that will increase volume can potentially increase intracranial pressure, and then again can potentially cause a syringomyelia, but that has not been shown, and there's really no research to sort of support those connections. But those of us in the mast cell world and those of us in this Septad world are always trying to sort of make the connection as to how one diagnosis can cause another diagnosis. And there's a lot of really strong and sound theories, frankly, and a lot of the research is that's that's being published is actually sort of proving some of these connections that we make. And that's just one of the connections that we've discussed. And so obviously I can't say for sure, but, and yes, it can definitely contribute to autonomic symptoms just by its basis of its connection with the cord. I mean, so the cord has autonomic fibers, and so it can definitely have a connection with the autonomic nervous system just on that pure anatomical basis. So I think it is related. To say more specifics of certainty, it would be hard to do at this time. But again, something that I'm so interested in, which is why I do the work that I do.
So I would just add something on mast cell here. Mast cells are everywhere, all right? They're most dense in our environmental interfaces like our skin and our gastrointestinal tract, mucous membranes, et cetera, but they're everywhere. They're wrapped around blood vessels and nerves. There's relatively recent research data from the neurosurgery people that, for example, tethered cord, the phylum is packed with mast cells. And I can tell you clinically, when I have a patient who's had surgery on their neck and then they do great, and all of a sudden they crash and their MCAS goes out of control, they turn out to have their tethered cord unmasked or occult. So it wouldn't surprise me at all that your spinal cord issue is causing mast cell activation. That mast cell activation, degranulation, could be causing your dysautonomia in POTS and vice versa. So it's an example of the multi-connections that we talk about. And, you know, I would, again, we can't make medical suggestions, but you might consider just some trials of mast cell medication just to see how you respond. They're very easy meds. They don't really have side effects.
Yes, that
Wonderful.
already they seem to be helping.
Good.
Wonderful. Great. We have Jennifer next.
Thank you so much.
Hello, I'm Jennifer Bell. I'm a family nurse practitioner with the Bateman Horn Center. Dr. Kaufman, I was interested in hearing your experience about rapamycin. We're about to embark on putting some patients on that, and I'd like to get a better understanding of what you have seen, what kind of side effects,
Sure.
and whatever else you want to share. Thank you.
Sure. So for those of you who might not know, rapamycin is a 50-year-old drug. I think it just had literally its 50th anniversary. It transformed transplant medicine. It allowed people to get donated organs without rejecting them. So it's profoundly, or can be profoundly, immunosuppressive. However, like naltrexone, in very, very low doses, it works at the level of what's called mTOR. It inhibits mTOR, and that promotes, when mTOR is inhibited, it promotes autophagy, which is a evolved biologic house cleaning mechanism to get rid of zombie cells that should have died through apoptosis but don't, and then they remain alive, and they are producing inflammatory molecules. And again, this is all related to the work in the aging longevity world. So we started using it based on some of that rationale and the whole autophagy concept. And, you know, what I've seen in low doses, roughly 6 milligrams a week, which is based on the clinical trials from done by Joan Manick in people over 65, there's essentially been no side effects. The most common side effect that can occur is mouth sores, aphthous ulcers, or canker sores. I've literally only seen it in 3 patients. It's, you know, you stop the drug, it goes away, and you can restart it, doesn't necessarily come back. In terms of, I have not seen any of the issues related to blood counts dropping or increased infections. So I monitor that. We do safety labs, but I haven't seen anything yet, anyhow. And I've been doing this probably close to 2 years. And in terms of outcomes, I'm going to just give you subjective reports. The patients, many patients, probably on the order of half to a little more, will say decreased fatigue, decreased pain, decreased brain fog. And that gets confirmed because you take a part of the protocol is to take a treatment break after several months, and they will talk about how some symptoms may come back, or they will forget to take their drug for a week, and then their symptoms come back. So, you know, it clearly has efficacy. I have not seen any significant side effects. And I've certainly had patients who don't report benefit But honestly, that doesn't mean there's no benefit. Sometimes you don't know, there's no symptom of autophagy. So it may be doing something good and it's just too soon to tell. The beauty of the study you're talking about that I'm doing as well is that we're looking at a biomarker that we hope will predict or relate to autophagy being up or down, and how rapamycin impacts on that. And my hope is it will also help guide us to the right dose, because I'm using the 6 milligram dose, but we don't really know the right dose. And drug levels, I don't think, give us enough information. So
Yeah.
hope that's helpful.
It is characterized as an
Thank you.
anti-proliferative, and it's a really effective drug, and it's been used in certain growth diseases, you know, for decades. I mean, we used to use it for tuberous sclerosis, for example. And I mean, we still do, but I used to use it all the time. So I have a very high comfort level with this particular drug. And I agree with what David said with regards to patients are seemingly receiving benefit without concerning side effects. And you know, so I think it holds great promise. I really do. I think it holds great promise.
Wonderful. We're going to have Tess come on and ask some of the questions from the Q&A.
Yeah, we got a few in the Q&A from clinicians. I'll start with Alba Azola's question, because she had headed to clinic. What is your experience with sex hormone testing and replacement, specifically females with low testosterone?
David?
Could you repeat it? I couldn't hear you.
Yeah, what's your experience with sex hormone testing and replacement, specifically females
Got
with
it.
low
Okay.
testosterone?
Yeah, I do routinely test male and female patients for testosterone levels, and very frequently find that their total, or more importantly, their free testosterone is either at the very low end of normal, inappropriately low, but still, quote, normal, or below normal. And I will routinely give testosterone replacement as usually as a cream to the shoulder or the abdomen. In men, I will sometimes use Clomid instead of the cream for reasons related to fertility and not wanting to suppress spermatogenesis. And, you know, for a subset of patients, just replacing their testosterone to a more appropriate level can significantly increase their energy, decrease their fatigue, and very importantly, not immediately, but over the long term, if they're able to do some exercise, it helps with muscle mass, muscle protein building, which is, you know, a critical problem in our patients that is very hard to address. So I always look for testosterone.
I think it's important to have a comprehensive hormonal evaluation, just to really be able to sort of somewhat guesstimate the appropriate dosage of testosterone. I mean, too much testosterone will be converted to estrogen. So you sort of do want to be careful if you're just trying to replace the testosterone. So I think a good hormonal evaluation, of which I fully admit I'm not the expert at that, but I do think that it's important for appropriate dosing, because I have seen where it was inappropriately dosed and there were some side effects that were not helpful to the patient. So
yeah, I mean, let me emphasize, the dosing is to get to a physiologic level.
Right.
Right. I mean, I have patients who are on testosterone, their levels are in the thousands. It's like, it's crazy. You can't do
I
that.
wasn't saying that you did the appropriate
No,
dosing.
no, I know, but I want to emphasize that, you know, the typical intervention is, okay, your levels are low, take testosterone, come back and go to the lab in a month to get new levels. All right. This is one of those drugs where you don't just prescribe it and disappear. I never give more than 1 month so that I make sure I get the levels.
Thank you. Well, unfortunately, we are out of time. Dr. Ruhoy and Kaufman have other commitments that they need to get to. And we know that there are a lot of unanswered questions. You are going to get a recording of this presentation. And we're also going to send you a link to join us on Slack for clinicians so we can continue the conversation. And we have more roundtables planned for the future as well. So please join us on the website, enter your email so you can keep abreast of what we have going on. Thank you.
There's so many great questions here. I can't believe we're not going to be able to answer them.
Oh my God, we would love to come back.
Yes, we can definitely have you back. If you have a few more minutes, we can answer another questions. It's totally up to you.
Well, I mean, I'm sure you have other clinicians you wanted to invite, like not just us. So we don't want to take the place of other really fabulous clinicians that are doing the good work for these patients, but we would be happy to come back. I'm speaking. for you,
Absolutely.
Bridget. I hope you don't mind.
Yes, yes, we'll have you back for sure. All right. Thank you, everybody. And we will continue the conversation on Slack. We'll send you an email with the recording. Thank you so much for being here. Thank you for your great questions. And thank you so much for being interested and being part of the solutions and being part of the provider network that takes care of ME/CFS, long COVID, and infection-associated chronic illnesses. We need you so much, and we are thankful to have you today.
And thank you,
Thank
Isabel
you.
and Tess, and the rest of the
Everybody.
panel for doing this. I think it's a remarkable project that you've ventured on. So
Yeah. Thank you
Thank
very
you.
much. I can't emphasize how important this is.
Shelley, did you want to add something before or just right before you?
Really
Thank you.
quick, we are doing this for you and we want to keep improving what we're doing with these roundtables. We've posted a link for you to give us a little feedback in a very short survey that is anonymous if you want, because we want the real truth. We're on a mission. Thank you so much
you.
for being here.
Thank you, everybody.
All right. Bye.
Bye-bye.
bye.